Thank you for giving up your time to take part in this interview, Richard. May we start by discussing your family background? And are there any other family doctors, for example?
I have three brothers. One was a pediatrician. He's retired. Well, um, he was running the. He had various. He was a clinical director at Guy's and Tommy's, and then at Oxford. My third brother is a psychologist, retired, and my eldest brother was an accountant in the oil industry.
Do you think that inspiration for most of you going into that field kind of stemmed from childhood, perhaps, or was there any inspiration there?
My father was a teacher, really, and my mother was a medic, and they met in the war because my father was wounded in North Africa, and in 43, I think that was, and then came home and was in hospital or whatever, and came across this nice young doctor who recently qualified, would have been in her first job or something. Obviously, they hit it off. I don't know what the GMC would say about such relationships these days, but it worked out. It was highly successful.
Yeah, and you've had many strings to your bow throughout your career. Perhaps if we start by focusing on your clinical role as a GP before retirement, and how do you think your patients viewed you as a GP?
I started life as a partner in a practice, I know I learned what being a real GP is all about, and I know it's very different being a part-time GP than being a full-time partner running a practice, having responsibility. I mean, in those days, you're doing nights and weekends, you're running the business, and running the business is it's an interesting and fun process running something.
Yeah.
There's a lot of reward in that, really. Really, the transition for me was when I came to the post in Leicester. Was I was previously a GP with a bit of research as a hobby, and it seemed to feel to me as I became a full, a researcher, proper researcher with doing some general practice as a hobby.
Mm-hmm.
I was actually very lucky to work in a practice that was accustomed to academics working in it, had been donkey's years doing that, and a great group of people to work with.
Doctors sometimes, not always, but sometimes tend to have quite a strong sense of identity from their work. And I'm interested in that shift. Like you say, you considered initially research as the hobby, the sideline, and then it swapped over. And how, I don't know, did that just come naturally, or was there a bit of conflict within you about that as time went on?
Absolutely. It's not something you feel necessarily, it's sort of had to be, but there were ups and downsides to it. I mean, I love general practice.
Yeah.
It was just fantastic.
Yeah.
Having your group of patients and people you got to know, and you're doing cradle to grave stuff was just because that's what you were doing in those days. We were delivering babies, and I could go from delivering a baby at 3 o'clock in the morning or whatever it was, or being at the delivery. You don't actually deliver it, but you're being there to, sort of, and then on your way home, you would confirm the death of some old folk in a rest home, whatever it was, and it was an extraordinary experience, and being able to that's the message about what general practice is. It's looking after people. It's not looking after patients.
Yeah.
The message is relationship-based care that's what it was. And that's really one of the first elements of the research I did was when I started off at Bristol, which I wasn't really expecting to find, but it involved investigating what was then called patient satisfaction, which was not necessarily a sort of reputable thing to be thinking about in those days. But anyway, that's what I was looking at, and I developed these because I'd been on a sabbatical in the US and come across some incredible folk. And there was one bloke called John Ware, who had devised all sorts of instruments for collecting information. He devised the SF-36, for example, and stuff like that. You just go around, knock on the door and say, "Oh, Richard, do come in." And they're just brilliant. And they were wonderful people. And he developed this method for using psychometrics for collecting information about patients' feelings about the care they'd had. So I used these methods to develop some questionnaires for use here. This is what I was doing in my practice, and then I finished the bit of work off when I came to Leicester. And coming through from that, so much was what predicted overall patient views of their practice, and it was primarily continuity of care.
It feels like it was just organically continuity focused and patient preference led almost, which is what everybody aspires to these days. But how on earth have we got away from that? And you say, it just came naturally that was how you practiced. And now it's almost, if we want to practice in that way, it's a fight, and it takes going above and beyond, or bypassing the system.
Yeah, I mean, it probably should temper things. It probably wasn't as rosy maybe as the receptionist was a dragon when we started in the practice. When I started as a trainee in the practice, the receptionist would be a dragon, pretty much. But over a period of time, that moved and became very different, because that's the way the practice was. That's how the team wanted it to move. So it started off probably as a fairly small practice with it is a lovely practice. I'm sure it's still brilliant, but it was a great place to be, and great team.
And a key interest of yours has been, see, the link between primary healthcare and mortality and life expectancy. And you speak of general practice as life-saving. And of course, this is going to be a very easy question for me to ask, but a more complex one for you to answer. But I wonder if you might be able to perhaps even just list a few mechanisms by which your work has demonstrated that, general practice can save lives. For instance, I know, as we've discussed, you're a firm advocate for continuity. Are there any kind of key features that say, look, this is why general practice saves lives?
I mean, essentially, the other element, my learning is the way general practice looks after populations as well as individuals, which is it's alchemy, really. It's magic. We deal with individuals all the time, but we have a list of individuals we look after, a list of people, in other words, our population. And all the time, we are also working with that population. And although we might not really want to think about ourselves as public health physicians, the moment you've got a list, you are, whatever we do is going to have impacts on a population. So whenever we've been doing studies, researchers, you can look at the work of individuals in qualitative research and stuff. But when you're doing quantitative research, you start to think about the population, and you can pick up things like way admission rates or emergency department use rates and things like that can be linked back to how a practice relates with its population, how much money it's got, how many staff it's got, how often, what's the access like, what's continuity like. All these things can influence the population and its use. And it's perhaps an area that is in practice, when you're in daily practice, not quite so aware of, and not quite so like to think about, and not quite actively managing the outcomes in a population. But I think one of the things that we could do better is manage the population outcomes.
Yep.
I think mortality is an interesting one, but I mean, I used to be of the view that we don't need to know about that, because as long as we're doing the processes of care, the things that research tell us in randomized controlled trials work, we don't need to worry about those things, because they'll take care of themselves. But it's just not that simple, because there are other things that we do that are outside trials and all sorts of other factors that that will influence that outcome, and if we're not aware of those things. So I think we do have to monitor outcomes and think about managing outcomes, a bit like a farmer manages their population of cattle or pigs or sheep or whatever. We have to be shepherds to our population as well, as well as being the personal doctor to the individual.
Yeah, and that's a tension, isn't it? With, again, another example of a conflict within. So you've got the conflict of the academic and the clinician. You've got the kind of, right, I need to focus on the individual person in front of me and the needs of the population, and the pot of money that we have to cater for everybody fairly and with equity and things. So yeah, it sounds like it's a constant internal battle to be a GP in that sense, because you're having to straddle so many different things. Is that why burnout is a very common thing to be speaking about, do you think?
I suppose it can be, yeah. I suppose it must be, mustn't it? What you want to do is fight your best for that individual.
Yeah.
That person in front of you, you want to do everything you possibly can for that person, because it doesn't feel right otherwise.
And your book entitled Primary Healthcare and Population Mortality, 2023, I think that was published, wasn't it? It reiterates that potential role of primary care in reducing mortality and the associated inequalities. And rather than primary care being viewed as this glorified triage mechanism, I'd be interested in your perspective on the role of the GP, perhaps back then and now and future, and perhaps we might then think about things like generalism and the GP being a gatekeeper and all these things that are bounced around in the literature and in policy and the media. But what is it that a GP is? Maybe building on where we started with the cradle to grave.
Yeah. Well, in some ways, we've narrowed the spectrum, haven't we? But I think that the basics, we provide relationship-based care. That's what we should be doing, I think, is right, because so many of the things that we do are easier to deliver, and you get better outcomes, and patients are more trusting and have better outcomes with relationship-based care. And we still care for populations, and I think those two legs I don't see how you can get away from them. So I think those two things. I think what's happened over my working lifetime is GPs have become, the impact on outcomes has increased for two main reasons. One is that medicine has advanced. So management of hypertension in the mid-70s, we could do it. And we got some basic drugs, but a lot of people, postural hypertension or whatever it was might be problematic. Nowadays, it's just great. And we're managing more people. We need to manage everyone, essentially, who can benefit. But at the moment, we've improved the number of people picking up gradually more and more. So you can find links between the proportions of people who are in a population managed with hypertension and their outcomes, which is so there's that. But at the same time, there's been a shift of some things from hospital care to primary care. And so we're doing more. We're managing more diabetes. The diabetes management has improved. A lot more people with diabetes, but diabetes management is much better. So a lot has happened. Cancer treatment has improved. And there's been such a focus on trying to find people sooner, the 2-week wait system and so on. And you can show that these things, like the 2-week wait system, is actually a good thing. And so GPs become more effective across and the range of work they do has become more. So it's an argument that process just flags up more. It's more important now to be thinking about the GP's role on outcomes like mortality and things like that, and managing that process than it would have been when I started practice. And that was, I think I was a trainee first in 77, I think it was 77, something like that.
And
so
and I mean the breadth of workload in general practice is, let's say, is broader. But do you think that means that GPs themselves are more generalist than they have been in the past, or is it that subspecialization is happening and actually people are less generalist?
Oh, I think very definitely we're less generalist than we were.
With more demand for it, I suppose. So,
well, I think partly we've reduced the range of things that we do because it's just become more of a, the amount we have to do has just grown and mushroomed. So was it 92, I think it was, or when was it that the out of hours work was taken over essentially?
2004, the contract change.
Was it? Yeah. Well, around about then. So there was out of hours work that we used to do, and that meant you were in people's homes at moments of acute things going on, and you were managing acute things. And that has gone largely. I mean, there's still out of hours services of one sort or another, but it's not like it was. You could be spending your Christmas day going off and visiting people at home. And you saw people differently, and they saw you differently. And, you know, I'd have to have people sitting in my front room waiting to be seen on Christmas Day, or the family were doing what they were doing. So there'd be those sorts of things. Maternity care. We used to do deliveries, home deliveries, maternity unit deliveries, and so on. And we'd have partnership with the midwife, and the midwife would know us and we'd know them, and the obstetricians would know us and we'd know them, and we'd go to the case conferences at the obstetric unit and things. That doesn't happen anymore, so that's gone. And so I think the role of primary care in childcare has probably narrowed a bit, really.
Yes.
Than it was. So those sorts of things have narrowed, but at the same time, it sort of deepened, if you put it that way, in other things like the management of chronic conditions, like it is a classic example, but I think mental health is probably another potential example.
Yeah, and it's just so interesting to me to hear you speak of, the midwife knew us, we knew them, and it was all very. You didn't have an iPhone back then, but it seemed that the communication channels were much more open than they are now.
Well, a lot of communication was face to face.
Yeah.
There'd be a weekly meeting.
Yeah.
Midwife would tell us who's expected, which deliveries are expected, whose patient that is. And, you would attend whether you're on call or not, because that's your patient, sort of thing. The same way that if you've got someone who's in the hospice, who's your patient, it would be that sort of service. A lot of the time, not all the time, because you might be on holiday, you might have to go and visit your own family or whatever it is. But there'd be things that, by and large, that would be what you try and do, and the midwife would. So-and-so's in labour, phone. So we didn't have a phone for on-call until I don't know when it was, and it'd be a great big block that you'd carry around, because it's a bit like carrying a block of concrete around with you, wretched thing. Yeah. But at least so otherwise you'd be reliant on a bleep that would call you.
Yeah.
And you'd have to phone home. So phone my wife, and she'd tell me so-and-so's phone, and they need to go and do this, that, or the other. So it probably would be slower.
But perhaps more intentional. I don't know. Perhaps maybe more planned, more thought went into it. Whereas now everything's just very immediate. There's not necessarily a need to think so much. I don't know. But let's change tack. Can we now talk about the Shipman report, and how did your involvement with that come about?
I was just asked to do it by Liam Donaldson, who was Chief Medical Officer then.
And how did kind of your involvement in that, it must have had an impact, not least kind of emotionally perhaps, but professionally. Was there any kind of change in yourself or in your practice or your interest that came after that?
Yeah, I got a call after, there was a trial, and then the next day Alan Milburn made a statement in the House of Commons, and this audit was part of that. It's going to be a public inquiry and things, but the audit, and nobody really paid much attention to the audit. So I was able to go off and do that fairly under the radar and hide, and was helped by some local people. You develop obligations to the victims, really. Although they're dead, they're expecting you to deal with this, that, or the other, or tell their story. And that was my first job, was to tell their story, really. And I know I put a lot of effort into trying to get down what the story was, but I couldn't not name them, but so the broad story would come out, and I think that was one duty, and the other is to try and do what you can to help the lessons from that get picked up by profession, by legislation, or whatever it is. And I mean, I'm not sure to what extent that's been successful or not, really. It's difficult to say. I suspect at the time, people didn't want to, they were saying, well, I think doctors in general and GPs in particular felt quite threatened by all this. Said, well, if he was a murderer, he wasn't a GP, he did this because he was murdered, not because he was a GP or anything like that. And didn't really want to think about what the lessons might be.
Okay.
So he drove for coach and horses through what was a pretty feeble set of ways that we might monitor, that we might reassure patients that it's all okay. So things have changed. Things have been, things have happened, and I think it's quite difficult for it to happen again. But I don't think enough has happened, and I sometimes wonder, for example, all these maternity services cases, and babies that have died. Why did it take so long, for example, for the medical examiner system to get put in place? It took decades. Absolutely ridiculous that it took so long. And maybe if that had been put in place earlier and had been generally functional, I don't know yet whether it really is a functional system or not, but if it had been a functional system, would they have picked up some of these problems with maternal deaths, infant deaths that might have been sorted out sooner? What about this? The mid-staffs, if they'd been quicker and got it sorted, then maybe mid-staffs have been picked up a bit sooner, things like that. And so there's shortly after the report that I wrote had been published, I went to, this was 2001, I was invited along by the solicitor to the Shipman relatives, the relatives of the victims, invited me along to go and talk to the relatives. And there were about 100 people there, and each one of them had at least one relative killed by shipmen. And I was in there with me, the solicitor, and them, and that was it. And so I was explaining these results to them. And I really wanted the whole of the medical profession to be there and listen. Every doctor in the country needed to have been there to answer, but I had to answer on behalf. And I think that made me completely different to any other doctor now, see things differently, unless you've been through a similar sort of process. And there will be some who have, and really understand I remember there was a lady at the back when we were talking about cremation fees, and she said, "Ash cash, that's what they call it."
Yeah, quite a unique experience, I'm sure. But yes, thank you. Thank you for your time today. We will leave it there because we could talk for years, I'm sure. But thanks for sharing your experiences.